What's up YouTube? I'm Mike and today I'm back with another bodybuilding video. This time I'm going to be doing a little thinking out loud. Let me fix my camera. It's always like a little cockeyed relative to where I'm sitting. Today what I'm going to be doing is basically some thinking out loud. I'm going to kind of take you guys into my process when I am studying various different medications for use in a bodybuilding context. I apologize if the audio seems bizarre in this video, like for example, if I'm screaming at you. I got an earplug stuck in my ear and did some kind of massive damage to my ear, and I can't hear hardly out of one ear. I feel like I've gone up a mountain and my ear won't pop. So I'm operating up. I'm a little fucked up today. So for those of you who've been following my channel for a while, you'll know that I am currently engaged. Oh, by the way, let me just say this. None of the information I'm conveying here is medical advice. Do not break the law. Do not do anything stupid. This is all hypothetical. I'm merely doing research with my own body, and I'm considering various ways of treating a variety of things. I'm not a doctor. I'm not a lawyer. Don't break the law. So for those of you who've been following my channel for a while, you know that I'm currently using 3 different 19-nor drugs. I am on nandrolone decanoate, 19-nor testosterone. I'm on mint, 7-alpha-methyl 19-nor testosterone, and I'm on trenbolone, which is 17-beta something or other. It's a nortestosterone derivative. I'm on 3 19-nor drugs, which means that I am currently taking 3 progestogenic drugs. These drugs all bind to the progesterone receptor with varying binding affinities. And when you agonize the progesterone receptor, you get a release of prolactin. And prolactin causes the dreaded decadic along with a whole host of negative side effects. I experienced severe bouts of depression, anhedonia. There's a variety of things that can go very wrong in the male body. And the female body, which I may be tinkering with my wife here pretty soon. Prolactin really can kind of fuck up your life if you let it get out of control. And so I have thus far been treating prolactin, trying to keep my prolactin levels in check by using a drug called cabergoline. Cabergoline is an ergotamine drug, if I remember correctly, and it reduces prolactin. It knocks out the prolactin in your serum concentration. So when you agonize the progesterone receptor, it releases prolactin, and cabergoline is effectively an anti-prolactin drug. So it reduces the side effects caused by prolactin. The problem is when you're an idiot like me and you've decided to run 3 different 19-nor drugs in ever increasing volumes, you basically become just an absolute assembly line for prolactin. So I'm running trenbolone currently at 100 milligrams per week. I just upped my deca to 300 milligrams per week, and I'm now taking mint, also known as tresbolone, at 15 milligrams a day. These drugs are all highly progestogenic. I'm currently taking 1.25 milligrams of cabergoline per week, and I'm afraid that dose is going to continue to rise as I probably continue to raise the doses of my 19-nor drugs. So I got to thinking while I was in the gym tonight, what if we could kind of get to the root of the fucking problem? So the root of the problem, in my estimation, is that we have 19-nor drugs that don't just bind to the androgen receptor, they also bind to the progesterone receptor with a high affinity. So what we're effectively doing is treating a symptom of a symptom. The 19-nor drug binds to the androgen receptor, and then it releases prolactin, and then we try to knock the prolactin down. But what if there was a way to stop the 19-nor drug from ever binding to the receptor to begin with? Could we do that? So I set out to find a drug that blocks the progesterone receptor, and I found one. Coincidentally, this drug is getting a whole lot of publicity at this time because the drug in question is called Mifepristone, also known as RU486. If you are following the news, you will know that Mifepristone is an abortion pill. It's an abortion drug. And the right wing in our country is hell-bent on making sure that every single baby that gets conceived is born. And so they have gone about outlawing abortion in a number of states all over the country. And then they went to the Supreme Court trying to get the abortion drug Mifepristone basically taken off the market. They don't want women to be able to have access to this drug. And the very conservative Supreme Court just recently, I think like 2 days ago, struck this down. So Mifepristone will continue to be available by prescription to women anywhere who want to have an abortion. So you're saying, Mike, why the fuck does a bodybuilder give a shit about an abortion drug? Well, because as I was saying earlier, the way this drug works is that it binds to the progesterone receptor. So this is a stupid name. I don't know if I'm even pronouncing it right. Mifepristone is a medication typically used in combination with misoprostol to bring about a medical abortion during pregnancy and manage early miscarriage. The combination is 97% effective. Yammer, yammer, yammer. We don't give a shit. What we actually care about are the pharmacodynamics of this drug. Mifepristone is a steroidal anti-progestogen. Now, of note, it is also an anti-glucocorticoid and, unfortunately, and this could be where we possibly run into a problem, it is an anti-androgen. In the presence of progesterone, Mifepristone acts as a competitive progesterone receptor antagonist. It antagonizes the receptor, prevents it from doing its work. In the absence of progesterone, Mifepristone acts as a partial agonist. Now, does anybody want to take a wild guess? Just a wild guess as to what kind of a drug Mifepristone is? I couldn't fucking believe it when I read it. I did not know this before I started doing this research. I'm just reading to you straight off the Wikipedia, and I get to this point. Mifepristone is a 19-nor steroid. Now we have a fourth. Is it possible that a fourth 19-nor steroid could be employed to prevent the other 3 19-nor steroids from ever binding to the progesterone receptor, thereby activating the receptor and causing it to produce prolactin? Could we cut the legs off of this beast and prevent it from causing us all of these problems? This is how my brain operates. See, I find a drug, I try to understand the pharmacodynamics of it, and then I try to determine whether or not there's any logical reason or biochemical, pathway that we could use this to get the desired effects. I'm guessing it's probably not going to work, but I'm just making this video to kind of walk you through my process. This is the kind of shit I do behind camera when I'm trying to come up with new ways to mutate my body or new content to come up with, or I'm faced with a problem like I'm making prolactin left and right, my nipples are going to start producing milk, and rather than get off the drugs that are just obviously causing the problem, I'm like, hey, is there a way that we could, what other pathways could we explore? So this Mifepristone is a 19-nor steroid, and it goes on with a bunch of chemistry you guys don't care about. In addition to being an anti-progestogen, Mifepristone is also an anti-glucocorticoid and a weak anti-androgen. I suspect that's not going to be relevant in the presence of massive quantities of androgens. The fact that it has some anti-androgen qualities is probably not going to be terribly important. Mifepristone's relative binding affinity at the progesterone receptor is more than twice that of progesterone. So, as I was saying earlier, in the presence of progesterone, which men absolutely have, we always have progesterone in our system. In the presence of progesterone, Mifepristone acts as a progesterone receptor antagonist. It blocks the activity of the progesterone receptor. This is partially how it ends pregnancies, because women need to produce prolactin and all of these things to be able to have their uteruses, not their uteruses, their cervixes and all their parts functioning properly in order to create a safe environment for the developing baby. But I don't give a shit about that. What I want to know is, can I block the progesterone receptor in my body from binding to the other 19 NOR drugs and head off the production of the prolactin to begin with? So it's a weak anti-estrogen. It binds with twice the affinity of progesterone. So it should which means it should outcompete the progesterone in our system, which means we should always have progesterone, and therefore the Mifepristone, the fucking drug, RU486, should always be acting as an antagonist to the progesterone receptor. It has a relative binding affinity at the glucocorticoid receptor of more than 3 times that of dexamethasone and more than 10 times that of cortisol. Its relative binding affinity for the androgen receptor is less than 1/3 of that of testosterone. So again, it's probably going to be outcompeted at the androgen receptor, and yet it's going to outcompete at least progesterone at the progesterone receptor. My concern is that we're going to have a situation where we're trying to impart another 19 NOR drug to antagonize the progesterone receptor, but all of the other drugs that I'm talking about, nandrolone, trenbolone, and tresolone, also have very high binding affinities for the progesterone receptor. So it's possible that they could outcompete the mifepristone for the receptor. No way to know. If you put all of these things in there together, it's going to be total warfare. Everybody's gonna be trying to get to the fucking the progesterone receptor. It's gonna be like the Dothraki horde all trying to get the girl. They're like fighting each other off, trying to get the girl. This is what's gonna be happening. It's like a Dothraki herd of 19 NOR drugs all trying to get to the progesterone receptor. Who can get there first? Who can bind with the strongest affinity? Can we get RU486 to the receptor first and stop the other Dothraki from getting a piece? That's what we have to do here. So it goes on to say that a bunch of shit that you guys don't care about, but this effectively is my thinking. This is the science part of it. We do have a drug that will bind to the progesterone receptor and effectively turn it off. It talks about the pharmacokinetics, the elimination half-life. It is after distribution phase, elimination is at first slow, the concentration decreasing by half between about 12 and 72 hours, and then more rapidly. So then it gets into the chemistry, which again just says that it's a steroid hormone, and it has substitution, C17 alpha position double bond. This might be hepatotoxic. We'd have to look into that. So the next question, of course, that I'm going to ask myself when I'm going through my process is, okay, so now I've found a drug that on paper does what I want it to do. At least has the potential to do what I want it to do. But it's an abortion drug. I mean, what happens if a man takes an abortion drug? Is this a good idea? Obviously, it's probably going to be safe, right? Because we take breast cancer drugs, a lot of the bodybuilding drugs we take were originally designed for use in the female body. So I suspect it would be okay, but I want to check to find out. So, of course, we go to Google and find out that Mifepristone, you know what, from now on we're going to say RU486. I can't get this fucking word out of my mouth. RU486 has received multiple FDA approved uses, including preventing relapse in male alcoholics. So they've actually used this drug to help keep men sober. So there we have one example of where this drug has definitively been used in men. The drug has also been used in a clinical trial, found that it reduced weight gain in healthy men who were taking olanzapine. No idea what the hell that is. And furthermore, this drug has been tested in treating post-traumatic stress disorder in men. A randomized clinical trial found that RU486 was not, unfortunately, effective in treating male veterans with chronic PTSD. However, the study suggests that future research may be of interest for men with a history of TBI, traumatic brain injury, or with a low rate of lifetime head trauma. So, it's worth mentioning, because this could really fuck my shit up, RU486 can cause some side effects. This is the one that sucks for me. Including low blood sugar, high blood pressure, lung disease, anemia, and bleeding disorders. It should be used with caution in patients with kidney and liver disease, as the body may remove the medicine more slowly. So in the trials that were done, for example, on the veterans, they were being given 600 milligrams per day for 7 days. What I was unable to find before making this video is any of these studies talking about the side effects that the men experienced during their course of treatment, which would be nice to know. You know, like what could we potentially be up against if we were to, I'm gonna be one guinea pig in this, if I were to try to use this. So this is the hypothesis. The hypothesis is that as fate would have it, I am currently massively producing prolactin because of my willingness to administer 3 19-nor drugs. Now here comes along a 4th 19-nor drug that on paper could potentially act as a progesterone receptor antagonist and stop the other 3 19-nor drugs from agonizing the receptor and creating prolactin. But again, this is all totally hypothetical. Obviously, there's no studies been done on this. I may fuck around and be the first to do it to find out what will happen, because I think that the only real danger that would be that we would be up against, or not even danger, I think the only thing that we would be up against is the fact that we've got 4 19-nor drugs that all, like I said, they're all like the Dothraki herd, and they all want desperately to get to the progesterone receptor. And so if this particular 19-nor drug is not uniquely potent at getting to the receptor and turning it off, and maybe even preventing the others from binding, then it's probably not going to be worth it. You're still going to be dependent on cabergoline to some degree or another, and so it's probably not as cut and dry as it would appear on paper. It would be nice if I could find another drug, in fact, that was not a 19-nor drug, that act more like what we really need is like the equivalent of aromasin for the progesterone receptor. We need a suicide inhibitor of the progesterone receptor so that we just knock the receptor completely out of action so that the 19-nors cannot possibly bind to it because it's completely shut. Well, I guess I misspoke there, because aromasin is actually a suicide inhibitor of aromatase, not a receptor. So we need something that irreversibly binds to and blocks the progesterone receptor, and I don't know if such a drug exists. Audience, this is your time to shine. Doctors, coaches, medical professionals, what do you think of my hypothesis? Can bodybuilders, can this bodybuilder use RU486, the abortion pill, also known as Mifepristone, to block the progesterone receptor and allow me to use massive fucking quantities of other 19-nor drugs to build a godlike bodybuilding physique? Can this be done? I am looking for a way to have my cake and eat it too. I want more gains with less prolactin and less dependence upon cabergoline. That's the objective. So my idiot brain goes, okay, well, let's just be dependent on a different drug. So yeah, it's probably pointless, but I thought it would make for some interesting content so that you guys can at least see how my brain works when I say it's time to go back to the lab again and cook up some new combination of steroids and ancillary drugs to try to get to this mythical creature that I'm trying to build, this unicorn body that is constantly recomping itself and building muscle while maintaining 6 visible abs at all times. This is the way the mad scientist that lives inside here does the crazy work that has brought you all of this content. So now you have been given a backstage pass into my process. I suspect that this one will not be a game changer, but you never know. Maybe it will be. So as always, thank you for watching, and we'll see you on the next one.